drug abuse, cancer,
measles, diabetes, AIDS, cancer.
Good evening once again and welcome to Doctor on Call. Yes, our usual Tuesday evening program at just about this time. We do apologize for the late start, but nevertheless we are here and we do have, like last week and all the other weeks, a very, very interesting program for you this evening. It's actually our second live program for 2023. And last week we discussed a number of very important issues, and we were quite happy with the significant increase in viewership of the program, and we hope that that continues, because what we do on the program is to try to share with you very, very pertinent information that can help you to be a healthier person, and of course information that can help you to take better care of yourselves. All right, so this evening, folks, we have a very special guest with us, Dr. Bert Brathwaite. He will be joining us. We'll be talking a little bit about the colon and colon cancer. In fact, we're getting ready to celebrate World Cancer Day, which will be on the 4th of February. So of course, for the month of February, we will be having a program or two on cancers as well. All right. Now, of course, Dr. Nixon is with me, but she's not my guest tonight. She's my co-host. So I definitely will be passing everything over to her. All right. So tonight, the discussion would lie between the experts, Dr. Nixon and Dr. Brathwaite. So let's say good evening to Dr. Brathwaite. Dr. Brathwaite, good evening. Welcome to you and Happy New Year. It's a pleasure to have you back on the program.
Good evening to you, Godfrey, and good evening to your co-host. In a new role, I see.
Yes.
Dr. Nixon.
You guys making Pappy show of me. Okay, go on. Good evening, everyone. Good evening, Dr. Brathwaite. It's good to see you.
Greetings to your viewers and listeners, and similarly, New Year greetings, although the 1 month is gone, but all the best for the rest.
Yes, indeed. So this evening, we're talking a bit about the colon and colon cancer. It's one of the common ones we hear about pretty often. And of course, it's important to understand what to look for, in case you start feeling a little indifferent from the norm. You will have a good idea when we finish with the program, when it's time to see your physician. All right. So, Dr. Nixon, it's good to have you. And of course, I will allow you to bowl the first ball at Dr. Brathwaite tonight.
I have to be careful with my colleague. Come sharp.
Oh, Dr. Brathwaite, I love you. And as a good West Indies cricket fan, West Indies forever, I will start. Good evening, everyone. And it's really a pleasure to have Dr. Brathwaite, who has been a long-standing physician here in Grenada, experienced internist with particular interest in diseases of the GI tract. Dr. Brathwaite has been doing a lot of investigations, especially that which a lot of us don't like, what we call scoping. Put something inside, look and see what's going on in the tract, and which we should be doing a little more to, for diagnosis of disease. But usually you don't just walk in and say, hey, I need colonoscopy. I need you to look up into my colon. Or can you look into my stomach? That's not how it is. For the most part, persons will present with some symptomatology that's related to the gastric tract. But I'm going to let Dr. Brathwaite speak tonight about all of this. Dr. Brathwaite, I've been on a medical school long, right? Really long. And I was a medical student when you're already a physician. So you look good for your age.
Yeah, thank you.
But I respect the time, the service you've given here. We all know that you come from elsewhere, but you're already Grenadian from a long time. And thank you for the services, because I think we need to diversify as health service providers. We need to ensure that all aspects of healthcare are available to our population. And so thank you. Maybe we should start talking about our challenges, diseases, what we feel, symptoms, what people feel, what should make them feel, I need to go to see my doctor, even my GP.
Yeah.
Okay. By the time people get symptoms, I'm hoping that a good part of the discussion tonight will go about what to do even before you feel symptoms.
Right. Mm-hmm.
Because colon cancer, like a few other cancers, can be prevented completely if you are you're monitoring yourself correctly. But in terms of the symptoms individuals will feel, it's often abdominal complaints, abdominal pain. Change in bowel habit is especially prominent. If there's some folk who like clockwork, get up on mornings, they have the cup of tea or cup of coffee, and either before or shortly after, they're in the bathroom. And that has gone on for them for years. And then all of a sudden, they find that there's this change. But it doesn't have to be as dramatic as that. It can be anything of the ordinary. You normally go once a day. You find yourself going to the bathroom twice, 3 times a day. And you're feeling sometimes that just after you come from the bathroom, you need to go back. You haven't emptied your bowels completely. So any change in bowel habit, that is one of the strongest signs, and that means you need to immediately see a practitioner and get an assessment. But in addition to that, pain, and the pain can be adjustable any part of the abdomen, often in the lower parts of the abdomen, but it can be adjustable any part. And I'm talking about early symptoms now. A bit later on, you might see some blood in the stool. But by the time that happens, it doesn't always indicate cancer. Blood in the stool can indicate many things. So you need to reassure folk that if they see blood in the stool, that does not mean you have cancer, but that means that you need to have your lower GI tract investigated. So blood in the stool. And then you go on to these symptoms that you might get quite a bit of discomfort in passing the stool and after passing the stool. And you then get on to the more serious symptoms now, which indicates that, look, this thing is probably has gone pretty far when you start to lose your appetite and you lose weight. And you might feel, almost like permanent discomfort in the abdomen from either a mass in the abdomen or fluid in the abdomen. These are some of the symptoms that you see. But that blood loss, anytime you see blood loss, perhaps we can talk about a bit about that, Sonia, from earlier. That is that blood loss, the commonest cause of blood loss rectally is hemorrhoids. Now, hemorrhoids are very common. And so people will think, I was diagnosed with hemorrhoids 5 years ago. This is my hemorrhoids coming back up. Well, indeed, in fact, it may be, but not necessarily so. Because if you, once you have had, I see just about every year someone who thinks that they've had hemorrhoids and went on with it probably a year or two. And really it was a cancer that they were bleeding from. So you must be investigating. Your colon must be checked out by some modality to make sure that it is not simply hemorrhoids that you're having. So those are some of the, and I should say that hemorrhoids are very common. But I'm not sure the percentage, but probably 1 out of every 5 people in our community will probably at some time have hemorrhoids and bleed from them. But do not assume that bleeding is and as a matter of fact, what doctors often will do is they will see someone, let's say you're a surgeon, and you go to the surgeon with hemorrhoids before the surgeon goes into repair, to resect the hemorrhoid, which is, there are other treatments for hemorrhoids, and that is going for the later stages. He or she will send you to have an assessment to make sure that your colon and your rectum is free of any polyps or any cancers.
Okay, so I want to give, because you said a lot of stuff in those few words, okay? So, let's back a little. And you did mention it in your introductory, when you're introducing yourself, the fact that, we don't wait until we get sick. So tell me, what a family is supposed to do to ensure gut health, just that you're healthy. So even before symptoms start appearing, what would you advise a family, young family, to do? Well, even before they start showing disease? What to cook, what to eat, what not to do, tell us, how do we prevent having problems with any gut tract from up here to down to the end at the anus? What is your recommendation for and those in the diaspora who are looking, because we do have a lot of friends out there who watch us,
yes, we do,
and who listen to us, because the information we give is important. And this year we are telling our guests last week that this year we're focusing on what we learn. So everybody who's looking tonight is supposed to take at least 1 point out of this message and apply it to their lives. We have to focus on being well. So give us some advice. I know that other things you probably can add. Give us some advice as to what
I would advise them from time to time, periodically, they're listening to you. Just listen to your advice, Sonia. Listen to the advice that you.
But you're the guy who got to speak tonight.
Well, okay. Basically, what you tell folk, we have a habit. People leave school, and you might leave school at 150 pounds, and you'll be 5 feet 7, 5 feet 9. And you turn 30, and you're 30, and you're now 210, 220 pounds. Right? That is not, that description I given there is not an uncommon one at all. So if you're going to, you have to do what is necessary to avoid weight gain. Overweight individuals are significantly, are more risk, I didn't say significantly, but are more risk of developing GI problems, and especially colon cancers. So eating, and what you eat is also important. All this refined food that we have around, abandon it. Go for your natural foods. Go for your root products that come straight from the soil that people from on. Right now, breadfruit is not root product, but it is in season. Your yam, your potato, there's a full of fiber. You want lots of fiber and vegetables. You want to eat lots of vegetables. In addition to the fiber, these foods having flavonoids and other substances that have anti-cancer effects. So it's about trying to control your weight, trying to keep fit. If you're diabetic, first of all, you're trying to avoid diabetes, and if you are diabetic, controlling it. Other risk factors for colon cancer are smoking. But fortunately, at least in terms of cigarette smoking, that has been considerably reduced over the years. I'm fearful of other types of smoking taking over. That's a different story. Smoking, alcohol, heavy alcohol content. Dr. Nixon, that's, I'm not sure what to call you, Dr. Nixon.
Doesn't really matter.
This is something that concerns me. When I watch what the young people, some young people are drinking, it is frightening. Many of them are going to develop problems into their 30s. They won't wait till they get into the 40s and 50s. They won't get problems into their 30s. Look, Canada has just cut back and said no more than 1 drink a day, right? They've cut back on the amount of alcohol. Many of us, including myself, we take a drink or two. But alcohol is part of our social well-being, but alcohol is basically a toxin, and alcohol will inflame parts of the GI tract and is a risk factor for colon cancer. So that's another factor. I mentioned alcohol, smoking.
Yeah, but can I speak a little about habits in the household? What to eat? What you used to eat as a young boy growing up in Barbados? What do you see people giving their children today? Because I think it's important.
I tell folk that basically your food that you prepare at home, using just what I said there, your natural food straight from the soil, not the refined foods that you get, your spaghetti and macaroni and all these things. You look for your natural foods. We have breadfruit in abundance right now. Yam might be going up, potato, dashi, tanya. These are the things that you're eating, of course. And your plate, one third of your plate at least should be vegetables. How many people make sure to have vegetables and fruits? On mornings for breakfast, basically you can take just some fruits and a cup
porridge.
Yes, some green wheat porridge of some oats, and you're off. You don't need to be going preparing any. I see sometimes, I was alarmed. I was traveling Barbados, and I saw at 8 o'clock in the morning people having early lunch. They leave the workplace. It was a bit later, probably closer to 9. They were leaving the workplace to come to a van that had pulled up, and they were having lunch at 9 o'clock. So that's their first meal. And by 2 o'clock in the afternoon, they're going to be back. So when they go home, they're going to eat a similar meal again. No, I have long preached and asked for, if you don't have fruits in your house, you're not eating healthy. You must have some sort of fruit. It could be banana. You know what is also very good? Pear. Avocado pear. You take some slices of avocado pear and biscuits, and you're good to go for the day. For the morning breakfast, along with some tea, as I say, and you're off to work. You don't need anything more than that.
So I brought up that point because I think there's one aspect of our public health expression that we're really trying to bring forth this year, which is very important. And that is the whole issue of childhood obesity. We have seen increase in childhood obesity. That means a child weighs over 35% of his weight for the height at which he's supposed to be. There's a table, you go to the doctor measure your weight and your height, and says, oh, you're right. Where the children of your age and your height and your weight, where should be for your weight. Now, we know that childhood obesity contributes significantly to adult obesity. So things like hypertension and diabetes, we already know is going to be worse. But the issue of gastric problems is also going to be a problem. GI, gastrointestinal problem, is also going to be a problem because it comes within that big ambit. And part of the challenges with our children is the fact that we don't teach our children, because you talk about some people carry their food to work, right? But they give their children crap because he don't like that. He like, you know that word? The word I use, what the hell is pasta? Okay? He like pasta, he like ramen, he like all the foolishness. That's unhealthy.
If the food is not comes from a plastic,
if it's not manufactured,
right?
If it's not processed,
and the tearing of plastic, a bag, it isn't good food. But that's wrong.
So we need to remind our audience of the importance of using natural food. You have said it, but I want to say, as opposed to using highly processed foods, which often has a lot of fats, especially trans fats that are not good for us, which often has a lot of salt, which is also not good for us, and which often has a lot of highly processed sugar, carbs. So you have high fructose corn syrup, you have flour, very
another
processed
risk
fat.
factor, Sonia, another risk factor therefore.
And that's what I'm saying. Those are risk factors.
High fructose syrup that you get in any product.
So just to remind our listening public that it's important how not only we eat as adults, because sometimes the horse gone through the gate already, but how we eat in families, in households, and how we teach our children to eat, right? Some of our children still think that, fig, I need to know fig, right? When in truth and fact, that's what was good. If you give a child a grain of boiled fig in the morning with some saltfish or some whatever it is you're giving as a protein, that probably keep them better. They won't be hungry. They won't be inclined to buy candy as they reach school or corn kernels or all the stuff. So that's very important that we're able to teach our children how to eat from very young. So the risk for developing later cancers is much decreased.
Yeah, agreed, absolutely.
I want to.
One of the things that we should point out before is that Black people have a higher prevalence or incidence of colorectal cancers. It's some 20% higher in men, and in females, it's 18% higher than the white counterparts. And
what contributes to that?
And it has also been found that as in recent decades, that the colon cancers are coming on at earlier ages. So much so that some of the international bodies have accepted that in Black people, we should start screening for colon cancers at age 45. Right?
I saw that.
And note this. Where are you getting the highest incidence of colon cancer? The highest incidence of colon cancer in Europe and North America, in the Pacific Islands and Asian areas. Much lower incidence, some of the lowest incidence, because these folk are on their natural, highly refined diets that we have turned away from. Partially that's certainly the factor.
Question or comment?
Right. I wanted to ask a question earlier. When Dr. Brathwaite was talking about the bleeding, from the hemorrhoids, and so as it relates to colon cancer and hemorrhoidal bleeding, is there any difference that you can identify in terms of how you bleed or what you see?
Can we leave it for a little later?
Mm-hmm.
Because I just want to just get a preview of what prevents. You come into those things. Is that okay, Godfrey?
Yeah, sure, no problem. Mm-hmm.
Yeah, because so that people can have a good chronology in their mind. So we think we cannot prevent for the most part. We try our best, right, Dr. Brathwaite? We try our best to prevent. And I know you want to look at colon cancer, but I want to look at some other things that are very cultural to us. Things like gas. And that, people tend to have a lot of gas. Sometimes
I have heard that from the time I graduated. Now, I don't know why to tell people today. Because over the years I've just but if you push me, I tell them, listen, everybody has gas in their stomach. There's a bubble there with air in your stomach, and there's air in your colon. Everybody has gas. Then if you start to develop discomfort in your abdomen, there's something that is wrong. No, I'm not saying that. It
may not be cancer.
But everyone from time to time gets a little discomfort here or discomfort there in the abdomen for a short period. But if you get persistent pains, and some of it is benign, it's a very common condition which we won't go into tonight called irritable bowel, and that can make you feel very bloated, etc., and crampy, and that's not a cancer. But the concept that I have gas is one that I'm trying to beat that, because we all have gas, and gas ideally should not cause discomfort.
So and I'm saying this because it's such a culturally ingrained thing that people accept, and it might be indigestion from something you've eaten. But if you have a chronic condition, I think it's something that needs to be looked at, because those symptoms are symptoms that persist. One of the things that we do in the Caribbean is we might have reflux, which is one of the most common causes of this gassiness. You know, you feel you constantly need to belch. The more you belch to try and get rid of that extra bubble, is the more gas, the more air you swallow, and it becomes this. But not only do we do that, we have mint. Now, mint is also known to be one of the biggest perpetrators of reflux. So when you treat your reflux, the doctor causes reflux. A lot of people just keep on taking the antacids that has a lot of mint and stuff without regulating their diet, without weight loss, and all the stuff that causes you to have some form of reflux. And they keep taking mint, and all they do is just doing that closed circle, right, that you never step out of. So I think it is important that we remind people that if a symptom like that is persistent, you kind of need to see a doctor so you can attend to it early. If it's persistent, even if you get treatment, go back to the doctor. And then after that, our doctors need to know that, hey, we need to look at and see what's going on here. Because sometimes it's a little more than just reflux or just a gas. So I just wanted to bring that point because it is a cultural thing. Mm-hmm. All right. Talk to me about... Godfrey, ready to take a break yet?
Okay, let's take the break now, and then when we come back, we would continue. Stay with us. We'll be back in a moment, folks.
Cancer.
Your life is yours. Your future's in your hands. Your body is yours. That's why you need a plan. You gotta plan your family, avoid HIV, get the education from the Grenada Planned Parenthood Association.
We offer STI screening, gender-based violence counseling, prenatal and postnatal checks, injectables, condoms, pap smears, and other sexual reproductive services. Open Monday to Friday, 8 a.m. to 4 p.m. The Pointe Street, St. George's. Whether male or female, it doesn't matter. We're here to make your life better.
Grenada Planned Parenthood Association.
For appointments, call 440-3341.
A GPPA clinic may be in a health facility in your area. Information can be found via Facebook at the Grenada Planned Parenthood Association. Clinics are in partnership with the Ministry of Health and GrenChap. This ad is sponsored by Canada Fund for Local Initiatives.
Here is a little known fact. There is only one place in Grenada that you can get an MRI scan done. That place is Spicile Imaging Center. Yes, Grenada, that's the truth. Other centers could offer you other scans, but Spicile Imaging provides an authentic MRI scan. Here's another little known fact. Spicile Imaging has 3 centers. We operate at Grenville, the Carnage, and at the Ocean House, Grandlands. We provide the widest range of laboratory tests and services. CT scans, x-rays, mammograms, ultrasounds, and a host of other services. We are fully staffed by a team of family doctors and specialists. Call us today at 444-7679 or 440-1500. or visit any of our 3 locations. Spicile Imaging, from seeing the doctor to getting lab tests, scans, and pharmacy services. We are here to take care of you.
Have you heard about the new Softweave bathroom tissue with total hygiene? As hygiene and safety have taken center stage, our bathroom tissue is now manufactured with 3 different technologies to offer the best protection for you and your family. UVC light technology for a safe and effective disinfection process, eliminating 99.9% of microorganisms. Also, production at high temperatures, killing all types of germs and bacteria. And it's pH controlled with delicate fibers to prevent irritation for even sensitive skin. Softweave Total Hygiene Bathroom Tissue, available in supermarkets and shops island-wide. Visit Softweave Caribbean Facebook or Instagram pages for more information.
Believe in our strength, we'll stand by you. Protection from all perils, big and small. It's so clear to see. Peace of mind, that's our service guarantee. We look after all our family. Yes, we do at every opportunity.
Antillean Group, underwriters of all classes of insurance solutions for your protection and investment. Live well financially.
If there was ever a time to keep and stay healthy, it's now. We at Hills and Valley are here to help you take deliberate steps to maintain your health. We stayed true to maintaining the most comprehensive rates while stocking the widest range of medicines and health devices, including personal protective equipment. There are so many benefits shopping with us. You get great savings through discounts for senior citizens and reward cards for loyal customers. Ask about owning yours today. Visit us at Halifax and Grenville Street, St. George, Jubilee Street opposite the Grenville Bus Terminal, and at Hillsborough, Carrico. Our wholesale distribution on Halifax Street also stocks the widest range of pharmaceuticals. We are with you on the hills and in the valleys. We are Hills and Valley Pharmacy.
Drug abuse, cancer,
measles, diabetes, AIDS, cancer.
Welcome back, everyone. It's Doctor on Call. Dr. Bert Brathwaite is with us this evening, our special guest, and of course, Dr. Nixon co-hosting with me tonight. We're talking a lot about the cologne, and of course, and folks, just for information, when we speak of the cologne, it's just another word for what we know normally as the large intestines. All right, and of course, we know. We've learned already that cancers can occur there. It is a common type, and so we're sharing with you information on how you can prevent that. And also, if for some reason you do feel something different, what you need to do and how it can be treated. So we would be opening our lines a little later on the program. If you do have any questions, we'll definitely be taking it so we can help in clearing up any little, issues you may have in probably understanding what was said. All right. So we're going back. Dr. Nixon, before the break, you were about to make a comment to Dr. Brathwaite.
No, I was just asking about upper GI problems, and we do have, because I think we have to address that. You're going to move on to the colon. But sometimes people end up having diseases that can be fatal. And I just wanted to talk about screening upper quickly, just 1 minute. And then we move on to the lower.
Okay, with respect to the upper
symptoms.
The symptoms you will get, obviously anyone with problems, difficulty in swallowing, and you find that you can't swallow readily, you have to take fluids to get the food down. Unfortunately, esophageal cancers often come on late.
That's cancer of the gullet.
Yeah, that's right. Yeah, that comes on late. But we don't see that as much today. Probably related to the decrease of smoking, I would suspect. Because we're drinking as much alcohol as we ever did. And we know that those harsh runs are irritant to the GI tract and to the esophagus or swallow pipe. In the stomach, peeing in just under the case centrally, that is a peeing that might often keep you awake at night. It's associated with a lot of nausea, makes you more full of a watery secretion. That can indicate an ulcer. Ulcers in the stomach, they are often in today's day and age. One of the things all the clinicians will be doing is checking for evidence of bacteria in the stomach. Because if you have an ulcer in the stomach or in the first part of the intestine, you need to check that you don't have this bacteria, because you can treat the ulcer and the ulcer will heal. But if you have the bacteria present and you don't get rid of the bacteria, the ulcer is going to recur quickly. So you aim to treat both to eradicate the bacteria and also to treat the ulcer. That also can go on to cause lots of vomiting, can cause you to bleed as well, and cause massive bleeding at times. Alcohol will often cause lots of stomach upset, and the whole stomach becomes very, you see, it looks angry. It's angry really for drinking too much rum. What you put that toxin, into me, and you go in and you see it. Fortunately, the stomach has good healing powers, and in order within a few hours it can be back to normal. But like any part of the body, if you continue to insult it and traumatize it by things such as drinking lots of alcohol and doing it frequently, then you are sooner or later going to run some complications from it. So those are, just a very, very brief overview of some of the common things. You can get cancers in the stomach as well, and there are many other causes of bleeding in the stomach, which we would like to touch.
So Godfrey had a concern earlier, which I think is very important, because when we move down to lower gastrointestinal tract, the lower part of your tummy, your intestines, your tract, however people want to call it, it's all correct. Bleeding from the rectum is one of the principal symptoms that we have. There are many causes of bleeding, and I think probably piles or hemorrhoids, as you say, is one of the most common cause for a lot of us. Tell us about the bleeding. Tell us why we bleed, and tell us how we can prevent that from happening.
Okay, the hemorrhoids basically dilatation of vascular channels in and around the anal and lower rectal area, and the blow up become prominent, especially if you had a hard stool. But even without that, you can just start to bleed. Quite often, the bleeding from it is not marked, but it can be significant. You can get significant bleeding from hemorrhoids.
And it tends to happen after your stool or before your stool?
You find out after you stool, and often initially you would just be getting the streaks of blood on the
feces.
On the feces, and it would be bright red, and a little bit of blood on the toilet paper. That's not uncommon with hemorrhoids. No, if you have a rectal cancer, not going to be too different, because you're going to be producing blood. What will be different there is that you'll be getting more you get abdominal pain, which you get pain in and around the anus sometimes with hemorrhoids, but if you get an abdominal pain, you're starting to think of other causes of bleeding from the lower GI tract. The lower GI tract, I mean the colon, rectum. And this can go from a cancer, but even it could be just something that there's certain bacteria that sometimes you get it, and it can cause bleeding, and the gastroenteritis, etc. And if you get parasitic infection, so you check and rule out all of those things. And what I would like to point out to folk is that the blood is not always not necessarily red. If you see darker colored blood, that is not coming from a pile. That's unlikely to be coming from a pile. That is coming from higher up the GI tract.
There's bright red blood in the lower abdomen, in the lower tract.
That's right. But if it's dark colored, that is coming from higher up, and it has changed nature, become the nature that is passed through the GI tract. No, not all the dark bleeding is necessarily a cancer, because you have something called diverticular disease. Very common, very, very common in our population, and especially in people over 60 or so. And the diverticular disease, the diverticular are like little pouches, which can occur any part of many parts of the GI tract, but especially in the colon. And you bleed from them, and sometimes they can cause torrential bleeding cancers don't usually cause torrential bleeding. If you see massive bleeding, that's not usually a cancer. Cancers will often cause steady, persistent bleeding, or in many instances, you will not be aware of any blood in the stool because it can just be dripping. The blood can drop, but you will not know it in any way because the blood gets mixed in with the stool. You don't see anything different, and that is the reason why it is important to do certain tests, which we can discuss.
Okay, so I've eaten all the bad food. I'm 35, 40 years old. When should I be a little curious that maybe I have a tumor growing in my colon, in my large intestines, especially in my descending colon, right? And at the upper sphygmoid. When should I be, what should make me worry? What exactly should make me worry? Because you were saying earlier in the break that we've seen a younger population, right? Coming with large bowel cancer. It's funny, I'll tell you. When I was in medical school, cancer occurred in white men 45 years up to 60. And I came to Grenada and I started seeing young men, 35 and up, young men. Now I see the gender kind of becoming equal. That's what I've seen among our Caribbean population. But I remember vividly, you'd see older white men, maybe, I don't know, maybe they had better equipment for screening, I don't know. But the bottom, you see older white men. But the truth is our diet has also changed to look like the diet of the first world. So probably that's why we're seeing more of us, and we're seeing us at a younger population. What do I, as a 40-year-old, when do I become suspicious? And what do I do?
Well, I want to take you back a step. I want to have you thinking about it even before you start to become suspicious because of something. And that requires every person from basically ideally through your life, but certainly from the time you reach 40 onwards, go out for an annual medical. And from the time you reach 40, and certainly 45, your doctor, and one of the tests you'll be doing just as you do, that's your blood pressure, you check your sugar, you detect the cholesterol, in males you're going to check your prostate, etc., etc. One of the tests that you do is to check the stool. We can discuss basically how you can pick up a colon tumor early. And we don't have the resources or the manpower where everybody can get this test, but everybody can have access to checking the stool for blood. And that should be done for sure after age 45 in every individual. Not without any symptoms at all. You check the stool for blood, and we can come back to that because I think it's important. I want to say a bit on that. Perhaps I should know. The test that you do for blood that traditionally we do there is called fecal occult blood testing by a wire method. This is a chemical method. I didn't want to go into all the details, but suffice it to say that to do this test, before you do this test, you should have, there are a number of things. You need to be off of tablets, especially painkilling tablets. You need to be not taking high potency vitamin C. You need to be on certain foods, etc. And then you go and do 3 stool tests, 3 different days. You take it up to the lab. Now, that's called fecal occult blood testing by the Brathwaite method. What is more precise, and which is from what I can detect, is only being offered by one laboratory, is fecal immunochemical testing, fecal immunochemical testing. This is a much more specific test. It is much more sensitive than the test we are doing. And so I'm hoping that we will see a lot more of these tests being done You don't have to do as many of those, probably one, some people say two at most. And you don't have to, the diet changes that you have to go through. You just go and you have that stool test. So as part of a medical, of every annual medical, should be a fit test. And if we did that across the population, we will pick up a lot of early cancers. There's another line of testing you can do, fecal DNA, but we can't do that here. That's a process you've got to get it to the laboratory within 3 or 4 days. And they send a whole box with stuff for you to do it. And you can only do that easily if you're in the USA States. But if we did the fit test through the community on a consistent basis, we could reduce the rate of colon cancers. And colon cancers, I should point out, are perhaps the second or third most common cause in men, probably after prostate. In females, you are a public health person after females.
I'm global health.
Global health, okay. In females, breast cancers, cervical cancers.
Breast, cervix, and uterus.
And uterus as well. Okay, right.
But we have seen an increase. Speaking to the staff at the oncology department, they have actually seen an increase in colon cancer among a population in general.
Yeah. That's the point I'm making. So to go back to your original question of not trafficking. So first of all, before you have any symptoms, to be aware that you can do things to pick up abnormalities from even before they cause you symptoms. When once you start to get these symptoms, this is changing water habits, intermittent abdominal pain you never used to have before. You notice any blood in the stool, you move, and you don't wait around and say, look, the doctor told me 2 years ago, or 6 months, or a year ago, that I had hemorrhoids. Yes, he or she was quite correct. But you also have another problem. So you're going to have hemorrhoids and you're going to have colon problems, colon cancer problems as well. Yes. So, and the only way you're going to do that is by checking the colon, as I said, for blood. But long before you get blood, small polyps develop. Small polyps develop like little, and we will show a picture of it. They develop basically the size of a pea. They can grow to like a cherry, to like a plum, and like a lime. They get bigger, and as they get bigger, and as the years progress, the cells change more and more, and then they will become frankly cancerous. If this tissue, when it is just like a blob on the intestinal wall, is removed, then you don't stand a risk of having cancer. So if your fit test comes back positive, then you have to be screened. We don't worry to do bare minimums. I don't know that they doing those in the hospital again. So it's basically by virtual colonoscopy or of a colon virtual colonoscopy using CT scan. The downside of the virtual colonoscopy is that obviously you're exposed to radiation. And if they pick up something, you still have to turn back and have the polyp removed. But it is, for many people, find it more convenient because it is probably less traumatic. The ball preparation is the same, and we will discuss a bit about the ball preparation for colon screenings via colonoscopy, or indeed via virtual colonoscopies.
All right.
Okay. Godfrey, you have a question?
Yeah, I wanted to just go back a bit because I don't think we had touched it as it relates to the risk factors. He briefly mentioned, African American people. But what are some of the other risk factors that can lead to colon cancer?
Colon cancer.
Mm-hmm.
Yeah. Okay. Inflammatory bowel disease is something we have to watch very carefully. If you have inflammatory bowel disease, refers to conditions in which you get ulcers and inflammation in the colon. And in some of the inflammatory bowel disease, it could be any part of the GI tract. And we have to go in and screen you for evidence of cancers. The screening period varies depending on how long you've had it, how extensively colon cancer, the inflammatory bowel disease. By inflammatory bowel disease, I'm referring to two conditions, ulcerative colitis and Crohn's. Those are the two inflammatory conditions that we are particularly concerned about. So that's one of the conditions. People who have had pelvic radiation, if you've had cervical cancer, have to have pelvic radiation. Or if you've had prostate cancer and you had radiation, you will be more risk. This is another group of people. Certain families, in certain families, if you have a family history of colon cancer,
or even polyps.
Or even polyps, that's right. We would want to go in and check the colon earlier. If you, for argument's sake, you had a sibling who at age 55 developed, well, let's say at age 45 developed colon cancer, at age 35, we'll start to want to screen you by checking your colon. So there's a whole number of things you do, and you become more detailed based on that increased family history. What other conditions that would lead you to colon?
Well, we talked about diet and low roughage diet.
We mentioned
right. Yeah. Low roughage diet as a high risk factor, and of course obesity.
And a diet high in
fat.
red meat. That's right. And lots of fat. Those are conditions that you would want to be
that put you at risk.
Put you at risk. And,
does it answer your question, Godfrey?
Yeah, I just want to kind of get an idea as to
and
how,
I think that's fair. Yes.
The other thing, I want to ask
Godfrey.
about generally. When people speak of cancer, you hear about different stages. Stage 1, stage 2, stage 3. Does that also apply to colon cancer, Dr. Brathwaite?
Most definitely. And if the cancer is just at the level of the surface of the lining, and they go in, they resect part, remove part of the colon, and you're good to go. If the cancer has gone deeper into the muscle layer but hasn't gone to the outermost layers, again, you're pretty okay. But from the time it goes through, gets pretty close to the outermost layers of the bowel wall, or goes through the bowel wall, those are higher stages. What you also look at, and what would also be assessed in the cancer is, do you have any nodes? You have lymph nodes that drain the lymph that run along the lining on the outside of the gut. And so those are going to be checked to see if there's any infiltration inside the nodes. And the body will, you also do scans. In our setting here, we will just do a CT scan. In the States, we will often do a CT and a PET scan combined nowadays. And you to check for evidence of spread. So you put all of those together to decide on a stage. And for the time it gets involved in nodes and certain, by the time it gets to spread, that means that after that section of the gut removed, you will often have to have a course of chemotherapy. For the rectum, it is slightly different. The protocols, but I won't worry to go into that. That summarizes what you
Brathwaite.
Yeah.
Dr. Brathwaite, you do quite a substantial amount of colonoscopies, looking into people's colons. Mm-hmm. Tell me about the incidence of precancerous, like polyps and cancer, that you find in our population, your experience.
We do see a number of people with precancerous polyps, not uncommon. I've never done any study on it, but I don't suppose that it is anything similar. Talking to my colleagues through the region, it's not anything dissimilar to what we see here. What frightens me though is oftentimes, too often, far too often, you see cancers. When I go into the colonoscopy, you're seeing a cancer that has gone through the bowel wall, and a cancer that is probably even something that's gone on to develop into metastasis. That is what we hope that people will avoid coming to that stage by having the colons checked on a regular basis. So as soon as that polyp develops, and the polyps will often bleed, and you can pick up the globulin from the test that they're doing, that we do basically. So
basically we're asking our population.
Age obviously is a factor. As you get older, you're more prone, even if you do all the right things. Because the average age for colon cancer developers in the 60s.
So basically you're asking me, as a Grenadian, as a citizen here, to just screen. Go look for it early. Make sure it's not there.
Go and look for it early. Any suggestion of any symptoms, get it screened. And we have
symptoms.
Huh?
And even without symptoms.
If you're having symptoms, but
if you're not
having symptoms, go get checked for it. Just like I think men are now getting more used to doing PSAs on an annual basis, right? Similarly, check your stools on an annual basis. Thirdly, obviously, if there's any frank blood, that's another reason for assessment. But it could be picked up early, and then you toss that away. All things being equal, you had a colonoscopy, you're negative, you're good, and you have no family history, you're good for another 10 years or so. I always tell folk, of course, if some symptoms start developing that in the intervening period, they may still need to be rechecked, because again, anything else, things could develop quickly, things could miss, etc.
So basically we're saying that it makes sense screening, because we know there are a lot of severe diseases, even cancer, that can course without symptoms. Right? So how often would you recommend? I do my colonoscopy. I'm over 40. I do my colonoscopy, my first colonoscopy. Let's say I'm 50. And I do my baseline colonoscopy, because that is what we've been asked before. You mentioned earlier that if I were in the population of darker skin, for whatever reason, we're seeing more fatal cancers. In other words, we're diagnosing people who have full-blown cancers already, and there are a lot that we can have a whole night arguing that, because that has to do with policy and access to care and all the rest of it, right? So we're saying I get screened now and I have no symptoms, but I just do my screen. When do I go back? What do you recommend for our population?
If you get screened and you have no polyps and you have no family history, that's important. If you have a family history of a first degree relative, we bring you back in about 3 years to check you still. If you have no family history and there were no polyps, 10 years. If you had a colonoscopy, if you had a CT colon study, or virtual colonoscopy using CT method, then bring you back in 5 years.
Once it's clear.
Sorry?
Once it's clear.
Once it's clear. Yeah.
So we need to tell our population that once you've had a challenge and a tumor is found, you're no longer just the responsibility of the intern as a person who just examines and treats by oral medication. So now you have to go to the surgeon. So that's the next path. If you do have a mass, a tumor, whatever you want to call it, you must be managed collaboratively with the surgeon and the internist and probably the oncologist. So it becomes a multi-disciplinary challenge.
Absolutely. I love that word, Sonia. You know, that's sweet.
You like when I use big words, right?
No. I know you're quite careful using the big words, but no.
No, but seriously, yeah.
What is sweet music to my ears here is that in medicine is not a one-man show. Medicine, you require many
partnerships.
Yes, many services, be it, well, in the case, I want to be in good contact with my radiographer. I want to be in good contact with my oncology team if the person's going on to get oncology. And my surgeon, obviously. And if the person needs some support, support from a social point of view, all of these things have to be put together to integrate.
Very important. And family support, of course.
And family support. Yes, the family going to come in that discussion. They're going to hear what is going on, unless you specifically say to the country, and hopefully they will be on board to help support you through it. And let me say though, that the good news about cancer is if you pick it up early. Listen, I've had people picked up in the 70s and they died for something else. Not colon cancer, they died from something else. So if you pick it up early, however, if you pick up the colon cancer now, when you get spread, your 5-year survival going down to like probably
30%?
20% or so. Yeah. Mm-hmm. So all the reason to go there and get, and even in our community here, we have lost a few prominent people from colon cancer who, if they were aware of the symptom, who could have availed themselves of the best of treatments, but they just weren't aware. So I'm glad that you and Godfrey are having this program to bring it to the highlight. And people are fearful of a colonoscopy. Perhaps, Godfrey, if you have the time.
Well, actually, my next question is on that. But just before, I just want to take a couple of Facebook comments because we have lots of people viewing. We have people from Toronto. We have people from New York. And they're saying, look, this is an excellent topic. And someone is asking, Doc, can you tell me what is a pile? And can it develop into cancer? I guess they're talking about hemorrhoids.
Sonia, you want me to do that?
Yeah, I'm gonna speak citizen, okay? Bert spoke doctor. I'm gonna speak citizen. So
a pile is a hemorrhoid.
Mm-hmm. A pile is a vein. There are veins around the anus and in the lower part of the gastric tract, and whatever it is, often is because of pressure. You know, you see people have veins on their legs, right?
Yeah,
so the veins are there under normal circumstances, but sometimes, whether you have a predisposition, because some people just develop veins because that's what happens in their families. Whether it is women,
yes. Mm-hmm.
Yeah, when they what? I'm sorry.
Overweight, obesity. Yeah.
Yes, it's coming to obesity when they have had a lot of children. Yeah. Right, that increased pressure in the abdomen from childbirth makes the veins dilate, and the same thing happens down in the and constipation in the case of those veins around the anus. They're inside the lower part and a little up inside. Once you have anything that increases the pressure within the abdomen, causing these veins not to be able to empty the thing, the veins get dilated, they get wider, and they become piles. The longer they're there, the more dilated remain. Just like a vein on your leg. If you lie down every night and wear stockings and do other things, the veins on your leg may disappear. But you already have a predisposition to those veins being dilated. It's kind of hard to get them back.
Okay.
So that's a pile. Once is a dilated vein that occurs around the anus. What's the next question against Godfrey?
They were just asking if it
can become a cancer.
Yeah.
No, it's not, because it's just a vein that's swollen.
Okay.
And the medications that we use to treat a pile, the symptoms, the swelling, is almost the same thing I use to treat the veins on your legs. So,
and what I think we should point out too, although we alluded to it earlier, that you can have a pile, and right beside the pile there, in the anal and rectal area, you can have a tumor. because
Yes.
rectal tumors.
So, but they were
are-
asking, they just wanted to explain what a pile was.
Yeah.
It's the
Yeah.
same thing when we get speaky spoke and use big word, we call hemorrhoid. That's what they teach us in medical school. But in Grenada, you guys said in Barbados too?
It's a
You guys
pile.
say pile in Barbados?
Pile.
Right. So it's a pile. It can become very, very, very dilated and get really engorged, really fat, really thick and tender and inflamed and infected. You can't sit down, you can't pass stools. And some people actually require surgical repair of their piles. The best thing, eat a lot of high fiber food so you don't ever get constipated. Watch your weight, and like what if you have another thing that might create increased pressure in your tummy, you have to eliminate that. But it's very important that you remove your poop every day. You go to the bathroom and pass stools so it doesn't stay there. The longer stools stay in your rectum, the more the body absorbs water, because that's where your body absorbs water, believe it or not, from down in your rectum. The longer the stools stay down there, the more the stool get hard and the more difficult it is for you to expel it. So making sure you eat a lot of high fiber food, callaloo and okra and oatmeal and breadfruit instead of pasta. What the hell is pasta? And all of that. The more you eat food that will create bulk, right? And make you form stools easily and make it easy for you to eradicate. Once there's no other obstruction, you should not develop piles.
Okay.
And that is why it's important to make sure that our children eat properly so they don't have to be afraid to go to the bathroom when the stool gets hard. And a lot of water.
And keep physically active. Get those
and
young,
physical activity.
Get those
Because
young
that
people
helps
out
increase
there.
the intra-abdominal pressure.
Get those young people out there playing some sport. Put down the tablets. Put down the phones. Yes.
Right. So I have one last question from one of our viewers, and then I have another question I would like us to spend a little time on. So a caller is asking, before doing a colonoscopy, is it best to do a home test with the poop?
But the home test with the poop would be equivalent of you go to your doctor and you get a form requesting to check for the blood in the stool, right? Occult blood in the stool, right? But if you are having symptoms, those even if that test is negative, you're having symptoms, and if you're over 45, then you should be looking to have a more specific test, either a colonoscopy or a CT colon study.
Right, excellent.
Hold on, Godfrey, don't go yet. Our guests speak of home tests, and we need to clarify that, You need to clarify that. I don't know if you would accept a home test that somebody does as a result for coming with a home test. Did you mention a home test? I didn't hear that very clearly. And we need to clarify what this test is that a person does, because we usually send our patients to the lab to look for occult blood. So somebody who knows what they're doing, using the proper reagents, does that. 2, Dr. Brathwaite, are we doing the immunology test, the immunotesting?
Yeah, one lab here does it.
Okay.
One lab in Grenada that I've been able to discover does it.
Right.
Okay,
so,
makes sense.
Yeah. So, Doc, my big question for you tonight, which would take us probably up to the end of the program. So, a patient is uncomfortable. They're feeling some discomfort in the stomach. All right. And, they're passing the stool, but they're still feeling like they have not emptied the bowels. All right, and they have concern, and they come to you, Dr. Brathwaite. Something is not right. I'm not comfortable. I need you to look in there. Explain to us what is done and the procedure, so that people can have a good understanding.
Okay. Godfrey, perhaps you could show the clip, now the 5-minute clip?
Yes, yeah. I've already indicated that.
I think that would explain it, and then I could clarify any points.
Mm-hmm.
It's a video taken from YouTube.
Yeah, we have something up that would explain the process actually. So you can go ahead. You might not be able to see it, but it's up. Yeah. Doc, are you hearing me?
Yeah, I'm hearing you.
Yeah, I'm saying we have something on the screen that you can explain the procedure, actually.
We can't see it.
Yeah, you won't be able to see it, but it's up on the screen. Yeah.
Is it running? Is it?
No, we couldn't use the video, but we have a couple slides up that would definitely suffice.
Okay, well,
Yeah.
The first slide that I have, is that the one that is up presently?
The one that is up, no, it's a different one because we couldn't use that. But the one that is up is basically one explaining through images the process of a colonoscopy.
Right, so there were 3 slides I sent you.
Mm-hmm.
One of those slides?
Uh-huh.
Let's go through it.
Yeah.
Go, Bert.
Okay, so the first slide, I'm assuming that the first slide is the one that is up. That one will show a small polyp. Is that what you're seeing, Godfrey?
No, that one is not up yet. We would get to the polyp, I think. What I'm trying to get is explain
a description of the procedure.
Yeah, what is done in order to find the polyp. Yeah, and then we'll come to the polyp. Yeah.
Yeah, I thought it could be better done by, well, to try to. It's a bit more than I'm going to say in short time, but obviously undertake a physical examination, you get to know your history, get to know what medications you are on, and then we speak to you about what the procedures involve. The procedure involves getting a full bowel washout. Colon cleanse, if you want to call it that. And the colon got to be cleansed because if there's a lot of stuff inside the colon, we will not be able to see something that is 5 millimeters or 10 millimeters. It will be covered by feces. So there's a specific set of steps that we take you through, tablets that we take, that's an ordinary laxative that we take first early in the morning before the test, and then in the afternoon, the day before the test, at about 4 o'clock, we give you this liquid to drink, and you drink that, and you drink lots of fluid after it, and then early in the morning, you have to get up perhaps around 2, 3, and you take another packet of the laxative. This time, it's a crystalline form of laxative. And again, you follow it with taking lots of fluid. You finish that up by taking something like 24 or so 8-ounce glasses of fluid, along with the laxatives that I mentioned. And what is important is that you cannot eat after midday. We allow you to eat up to midday the day before the test. We restrict your fiber content that day and your vegetable, etc. That's the day before the test. But after midday and the day before the test, just fluids. If you don't eat, again, the test will be spoiled. So after that, your bowels will be prepared. You come in and your vital signs will be taken. You seek to check out that all is well with you. And then we proceed to do the test. And during the test, we'll sedate you as is needed to make you comfortable. Or in some instances, we do it just as we do it in the United States, where you're fully sedated. But that time, there's another doctor who joins me along with a nurse. So we have a full team there, and you are fully sedated. You feel absolutely nothing. With the lesser sedation, you will get a little bit of discomfort, but we minimize it by giving medication when necessary. If we see polyps or if we see inflammation, we take bits of tissue to send to the lab. We're taking the bits of tissue, we use a biopsy forceps. If you see a polyp, which, as I said, starts out like a small pea, then we take what is called a snare, and it has it's a metal structure that comes on through a sleeve, plastic sleeve. You open it out. My assistant nurse opens it out. I guide it directly over the polyp, and then you pinch it and remove it. There are other techniques you can do for removing the polyp. You remove the polyp, you send it to the lab for analysis. If the polyp comes back and tells you, especially the bigger polyps, you're more worried about, that it has certain features, you will be even more careful. If it tells you it is not showing those features, where you feel more reassured. And obviously, if it has worrying features, you go back and inject quicker. So that process is called polypectomy. By removing the polyp, the polyp is the growth, that extra the tissue that is bunched up. You remove that tissue, and once you remove that tissue, and you get a good clearance, you're not going to get cancer from that polyp. You get cancer from other areas, but you won't get cancer once that polyp is thoroughly removed. Sometimes you use a bit of coagulation to remove it as well, depending on the nature. I mean, the bigger centers, they actually, instead of doing surgery, can go in and peer to the peer at the top levels of the lining of the intestine, but this is a more sophisticated, really more sophisticated equipment and backup facilities, etc.
So just briefly explain to us the instrument that is used, because you said you spoke about the insertion, but is it a camera? Is it what is it that is inserted?
Okay. You use a colonoscope to insert, and the colonoscope it's just like a thin tube that you pass up through the rectum, and you worm it around the rectum, but the rectum is not a straight tube. It has some S veins and it has some big angle veins. So you got to try and straighten the colon, not the rectum, I should say, the colon. The colon is not a straight tube, the rectum is straight, but mostly. The colon is not straight. The colon has veins in it and has right angle veins in the veins. So you try to straighten these out, and you also try to shorten the colon, and so that you can progress right around to get right into the first part of the large intestine, which is called the cecum.
Uh-huh.
The cecum, and you can often also get into the lowest part of the small intestine, called the distal ileum. That's ileum is the lower part of the small gut, and distal means the furthermost part of the small gut. So you can go from the cecum, you can peep into the distal ileum. Sometimes it's very important to do that to pick up what might be happening in the small intestine. So you go right around, and when you go right around, you come back, you inspect. If you see nothing, if it all looks good, you come back out, you reassure the person, you're good to go. If you see polyps, you remove those one time, you trap them, and you send them to the lab for analysis to find out what's the state of this growth. Is this growth looking like a strong precancerous one or not? Or is it already a cancer for that matter?
Mm-hmm. So yeah, if let's say you identify some polyps and you've removed them, what about the possibilities of them growing back?
If they're completely removed, they will not go back from that area. You get other polyps coming back up other areas. I've had already a patient with about 6 polyps who had many polyps some years back, but he's smart enough to recognize that he's at risk. He has a propensity for developing these polyps. So he's come back, he came back and he was checked, and those were removed, but he has to come back in short order again to have, when I say short order, within 3 years or so, to have that colon be checked, but that's the exceptional case.
Okay, wonderful. Dr. Nixon, any additional question you would like to ask Dr. Brathwaite?
No, I just wanted to say that this is a lot of new information because we haven't really shared the information, and we're talking about increasing colon screening in our population because we've seen that increase in incidence, new cases, among our population. So I think this is a good start. I think this is a very good start for Grenada and people out there who are listening, all my friends in Canada High. But the truth is, we have to continue this conversation. We have to continue a dialogue between us as health caregivers and really kind of converting ourselves into primary health caregivers, focusing a lot on primary prevention. And like I tell you, like I said initially, our children are very important because for a lot of us, the horse gone through the gate. The truth is we have to start teaching our children how to make good decisions in order to have healthy outcomes. Remember, Dr. Godfrey, a lot of the things we talk about, we look at how do we prevent death. So we can live to a ripe old age, right? How do we prevent early serious illness, right? And remember, above all, how your family, the social effect of diseases like colon cancer. The fact that, for example, we don't have hospice facility, meaning there's no place that when you become severely ill, for you to go and be comfortable if you're going to pass on. No, I wouldn't say you. If one becomes severely ill, a person becomes severely ill, there's no comfortable, scientifically designed place where they can, live the laughter of their life in some level of comfort. There's no, and our families are not trained to manage us. So everybody just, bump as they go along. You see a big stone, you jump over that, without really creating a smooth way to manage. Therefore, it's very important that now we have another bad friend on the block. How are we going to keep him from coming on the block to start with? How are we going to, ensure that we follow him up if we keep seeing people around the corner to know when he's really on the block and we can't get him out? What else can we do to ensure that the block remains safe? We be in the block. Okay? So I think this is a new thing for us to think about. I think there's a lot of ways we can focus on how do we prevent us from getting sick, right? We're scared about cancer, but we have control, as Dr. Brathwaite said in the beginning. There are things we can do to prevent ourselves from having severe diseases. Yeah, we're gonna die one day, but everybody wants to sit down in a rocking chair and get sun long before they're dead.
Yes, indeed. Dr. Brathwaite, any final words you want to leave with our listeners?
Yeah, but one, continuing from what Sonia said, one of the things we must recognize is that we do not have access to some of the levels of care that you can get elsewhere. But if you wait until the horses go down the stable and the cancer is spreading, we don't have facilities here to go and do any resection, the metastasis, which is what they do, is depending on where the spread has gone, the section of the liver has gone to. So it is more incumbent upon us to be careful to limit the chances of us ever reaching that stage, but being cognizant of what is involved, what are the symptoms that you get, what can I do to avoid it, and the simple thing that the whole population can do. Fit tests are not expensive, right? Fit tests of $45 or up there, around somewhere of that kind of order for one fit test. And just by doing that alone, and you can avoid it. And recognize as well that some of the agents that they have, some of the biologic agents, we haven't spoken about that. We have the chemotherapeutic agents here, but we don't have, to the best of my knowledge, much in the way of biologic agents. And that's the way the care for high stage cancers is going, where you look at the particular type of tumor and give biologic agents to counteract that will best work based on how the nature of that tumor as you discovered it from the DNA analysis. So I would say before, just be conscious, keep conscious of those things, if something's happening. And don't be fearful. One of the biggest problems we have is fear. But I even have colleagues who would not go and get a colonoscopy, right? And I'm not sure what they're fearful about. It's better to go and get a polyp removed that is not a cancer than to hear the news reading that you have a cancer. Why?
Right.
Why? And it is not a painful situation. yes, anything in medicine, I'm not saying it's 100% pleasant, but we know what to do to decrease the level of discomfort. And after the procedure, most people walk out, go home, and they can eat the same day. They can't drive the same day because they're fully sedated and or even partially sedated, but they can go home, they can eat and whatnot, and move around at home like normal, pass with a bit more air than usual for a few hours, and that's it, right? It is simple as that.
Right.
So, listen to Godfrey and Dr. Nixon, and take any symptoms, new symptoms, especially that you're developing, seriously. There's a lot more we could have said how to differentiate it from irritable bowel syndrome, etc., but that's all for another story.
But definitely, Doc, we will be having you back because these are issues. Colon cancer is common. It's very common. It's one of the common ones. You hear about it. So it is a discussion that we need to continue. Last year, we did a lot of work on some of the chronic conditions, the cancers, the diabetes, the hypertension. A lot of work was done on that, and we have to continue. Of course, we intend to spread our wings a bit and touch some of the other conditions, but definitely the conversation on our health has to continue. So we will.
Godfrey, before you disappear, because you sound like you're running through the door already. Remember, next month is Cancer Awareness Month.
Yeah, I'm very much aware.
We're going to be talking about cancer still.
I did say so. In fact, I said we're starting off with colon cancer.
But I want us to remember that the factors that put us at risk, the things that we do that put us at risk for colon cancer, kind of look like the others, doesn't it?
Yes, old age, African American race, a personal history of colorectal cancer or polyps, inflammatory intestinal conditions, inherited syndromes that increase colon cancer risk, family history of colon cancer, low fiber,
diet, exercise,
low fiber, high fat diet. We love chicken and chips in Grenada.
Fried chicken.
We love fried chicken and chips. A sedentary lifestyle, people who are inactive. So you need to get up and exercise. Diabetes, obesity, of course, smoking, alcohol, and radiation therapy for cancer. These are some of the risks. Also, there are lifestyle changes that can reduce your risk of colon cancer. And some of them are eat a variety of fruits, vegetables, and whole grains. Drink alcohol in moderation, if at all. So you might be better off not drinking at all. But if you have to, moderation, very little.
I want to just make a point quick about alcohol here.
There are one or two families. There are a few families in Grenada who have perhaps some of these syndromes. You pick up families in different parts, and of course, once you see a family like that, you get in and get all the relatives, and you try to encourage them to come up and be screened.
Right.
So there are families with some of those syndromes.
Definitely. So, yes, let me just complete this. So, drink alcohol in moderation, if at all. Stop smoking. Exercise most days of the week. And maintain a healthy weight. And these can help you to significantly reduce your risk of colon cancer. So,
I want to talk about alcohol quickly, sir. I'm not even talking about the accidents that we've been seeing. I know Grenada is special, like I said today, because for some reason, I think we know how to turn over a car on top of its roof more than everybody else in the world. Almost every accident I see, a car on top of its head and the four wheels in the air. You've got to be careful. But I know there is a lot of alcohol consumption before we hit the road. And to my dismay and shock, one of our favorite bears has increased its percentage volume of alcohol by 50%. That was 4% by volume, is now 6%. I'm sure it tastes nice because the original tastes nice, but I'm asking people, please contain what you drink. Please, You only need 3 drinks, 4 drinks, you can't focus on what's going on. And the more you consume alcohol, again, the more you're at risk for developing cancers and almost every disease that we're concerned about. So I'm going to ask our young people in particular, please do not drink and be responsible.
And you know, Sonia, that I've observed some of the parties that they have, I won't mention which ones, you see mostly younger folk ready to go to the party. And some of them high already, you know.
And our women are consuming more hard liquor than our men.
Yep. Yes, indeed.
So we're going to move on from that. I just want people to remember, talk to your friends. You know, just as how you and your friends do things that are crazy, we can do things that are healthy. So we need to collaborate on that one. Start in the workplace. This year, the Ministry of Health wants to focus on mental health and physical wellness. Yes. And I think it's not just the ministry, it's all of us. How do I preserve my mental health? What do I do? Where can I get help to ensure? How do I stay well? Right? We have primary healthcare clinics. Yes, some of the services still a little short, but a lot of the basic services are existing. Dr. Brathwaite spoke about getting checked in the beginning. Check every year. You can go to a health center and get seen for probably nothing. Do that, okay? Please do that. Please teach your children, take your children to the doctor every year so they can have all the checks. They can, especially their weight. The whole obesity thing is an epidemic for the world. But the region of the Americas, the Caribbean and South America and North America have the worst statistics. We have the worst, and we have our children accustomed to run up and down and play and do things outdoor. We have to take back that lifestyle to prevent things like colon cancer when you get to 35.
Yes, indeed.
We have what it takes. We have what it takes to prevent those diseases. What we need to do is to do what we need to do. What we're doing here is taking horses to the water and we're asking you to drink, please, right? We can't drink for you, but everybody has a responsibility. We have to go to that place. So tonight I'm going to ask everybody, like everybody I meet on the street who has been talking, and as is a mantra this year, take something out of this and apply it to your life. Are you going to get more physically active? Are you going to stop eating the fried foods? Are you going to dash away the pasta? Are you going to eat more locally grown foods, smaller quantities? Are you going to, really be responsible? Just bring down the alcohol. Whatever it is, create at least one habit from what you hear tonight. And together we'll all be around till God knows how long.
Yes, indeed. Dr. Nixon, Dr. Brathwaite, I thank you so very much for making yourself available. As I said, we will be calling on you again, from time to time to be on the program to continue to share information. So it was indeed a pleasure. I thank you again so much, Dr. Nixon. Thank you so much. Of course, next week we may not have a program. I think
it's Independence.
Yes, it's Independence. So we will be celebrating 49 years of independence in Grenada, but the following week we will be back. And just to remind you folks before we leave, tomorrow at 8 o'clock, the premiere of our newest program, our Climate Reality. It will be on GBN TV, on K105 and all our social media platforms. Tomorrow evening we're opening with a detailed explanation on what is climate change. When we speak of it, what are we talking about? Yeah, so we have joining us tomorrow evening, we have a climatologist from the Met Institute in Barbados. His name is Cedric Van Merbeck, and also a forecaster from the Maurice Bishop International Airport, Mr. Gerard Tamer. They will be joining us tomorrow evening to go in detail on climate change. And of course, as the weeks go by, we will share with you a lot of important information. How are we contributing to climate change? And of course, what climate change can do to us in return. So join us tomorrow at 8 o'clock for the premiere of our Climate Reality. Thank you very much, Doc. Thank you very much. Do have a good night.
Thank you for having us.
Yes, all the best. All the best, everyone.
Happy anniversary. Happy Independence, Grenadians.
Yes, indeed.
And happy and sober independence.
That's right.
Yeah,
all the best.
And don't eat too much oil long, and don't eat too much pigtail and too much fat and too much salt. But have a good time, have a good, safe, and happy time with you and your families.
Yes,
Thank you, Dr.
and
Brathwaite.
also our friends on our Facebook page, we thank you very much.
Yes,
I
thank
see
you.
the names every Tuesday. As a matter of fact, they're on every program. They are ardent listeners and followers of the network. So we thank you, Monet and Dodo and Yulin and all the others. Thank you very much. We love you guys. All the best. Do have a good night.
Night, everybody.
Night.
AIDS, cancer,